This conference will now be recorded.
Right. So I just want to say a very good morning to all of you. This is the first time I'm taking for your badge, but let us make the rules very clear. So I see only very few of you have joined in the last few minutes. Just people are pouring in. But next time onwards, after 9:10, we will close your attendance, and whoever is coming before 9:10 will get your attendance. Right? So we don't want this disturbance all the time pouring in and leaving in between. So please be very clear on that. Okay, today we'll do stages of labor. Did you have a class on this stages of labor? Anyone? Did you have a class on stages of labor before? Then one of you unmute and let me know.
Students, can you hear, ma'am? Say yes or no? Please unmute yourselves.
Sirisha, roll number 100. Sirisha, can you unmute yourself?
Yes, ma'am.
Can you hear?
Yes, ma'am.
Okay, fine. Right. Did you have a class on stages of labor before? Did your batch have a class on stages of labor before? Hello, Sirisha.
Yes, ma'am.
You had a class?
Yes, ma'am.
No, we just want to know what topics were over. Who's the class representative? Guys, can you hear or not? Is Sirisha on?
Ma'am.
Yeah, can you hear?
Yes, ma'am.
Okay, okay. We just want to know if this topic is over. Stages of labor, has somebody covered it before? If it has been covered, we'll just rush through as a revision. Anyway, if it has not done, we'll go through it. That's all I want to know. Because this is a very basic topic and I want all of you to be thorough with this before we proceed further. So you are not sure whether we had the class or not. It means as good as not having it before. Okay. So
No,
we
ma'am,
have 4 stages. Yeah?
Chapter, ma'am.
Chapter, okay, fine. That's good. If you have not had it, let's do it in detail. I just want to know if it's like a revision class or if you have not done it before, we'll do it. That's all. Right. So stages, as all of you know, obs and gynae relates very closely to mechanism of labor, stages of labor, everything related to labor, isn't it? Obstetrics is all about delivering babies. So 2 very important questions for any patient who is pregnant is how to deliver and when to deliver. So what are the methods of delivery if somebody has to deliver either by a normal vaginal delivery or a cesarean section? So the common one which one should have or which is most safe is a normal labor. So before deciding whether we can have a normal labor or cesarean, every one of us should know what are the basic stages of labor. So normal labor consists of 4 stages. Out of these 4 stages, what do we have in each stage of labor? Next. Right. So the first stage of labor starts with the onset of labor pains. So we all hear about somebody going into labor pains, isn't it? So whenever somebody has started with pains, you call that onset of labor. Now you should be able to relate whether that pain is true labor pain or is some other pain. We can have various other causes of pain, isn't it? So you should be able to ascertain whether it is true labor or not. Then when does the first stage end? It ends with full cervical dilatation. You know the cervix is normally closed and the uterus is carrying the baby all through these 9 months. But at the end of first stage of labor, the cervix totally opens up. It leads to full dilatation of the cervix. So how do we know that it is true labor? So whenever there is pain, patient is complaining of pain, you normally think it is true labor. But suppose you are in labor room, you are on duty, and the patient has come in pains, you have to make sure, otherwise suppose it's not true labor, you'll be sitting with her all night and she will not even deliver. You have planned something for yourself and you're sitting there without any reason. On the other hand, if somebody is in true labor and you don't take care and you've gone for a movie, leaving her alone, what will happen? It will progress and it might have problems if you have not monitored the patient. So it's very, very important to first of all identify if patient is in true labor or not. So how will you do that? So first stage of labor starts with uterine contractions, which are responsible for the pain, the true labor pain. Then there is something called mesosanguineous discharge, that is what we call show. There is cervical effacement and dilatation, and the fixation of head at the brim of the pelvis, and rupture of membranes. Okay, so coming to each of these things. Before I go to this, I want to tell you that true labor pains should be differentiated from false labor pains by very important feature, that the true labor pains will be progressive in nature, progressive in duration, frequency, and intensity. That means with each next pain, the pain will be more severe than the previous pain, and it will occur more frequently. Suppose initially the pain was occurring, the contractions were occurring say once in half an hour, then it will occur once in 15 minutes, once in 10 minutes, then every 5 minutes. So the number of contractions will go on increasing. Similarly, the duration. Suppose initially it was lasting for 30 seconds, then 40 seconds, and so on. It will go on increasing in duration. Next, intensity. That is the strength of contraction. The pain will be more and more intense as it progresses. Whereas if it is a false pain, it has no such progressive nature. It will occur haphazardly any time, and it has no progressive intensity, duration, or frequency. That is one feature. The second feature is that it will be associated with cervical effacement and dilatation. Now, what is effacement? What is dilatation? Now, dilatation is opening up of the cervix. The cervix is normally closed, and when the cervix opens up, it is called dilatation. So, when we clinically assess this dilatation, it is full dilatation is 10 centimeters. Now, you can't obviously put in a tape inside and measure that. So, we do a pelvic examination with two fingers, sterile gloved hands with a lubricant, and you see inside whether, if it allows one finger, it is roughly say 1 centimeter. If it allows two fingers, 2 centimeters. Now after that, you don't put 3, 4, 5 fingers. You just put 2 fingers and see the distance between the lips of the cervix. So roughly, if it is this much, say 1 finger in between, it is about 3 centimeters, and so on. Then you can just feel a rim of cervix. It's about 8 centimeters. And when there is full dilatation of the cervix, that means the cervix is totally opened up. What will happen? The uterine wall will become continuous with the vaginal wall. That's when you call it full cervical dilatation. Okay. So that is the end of first stage, when the cervix is fully dilated. But here, whenever you find that the cervix is opening up along with uterine contractions, that is a feature of true labor. Now the second thing is effacement. What is effacement? Effacement is shortening of the cervix. So normally the length of the cervix is about 1 inch, 3 to 4 centimeters. Now as labor progresses, the uterus is contracting, and it takes the cervix into itself. The body of the uterus will pull the cervix into itself, the length of the cervix, so that it goes on becoming shorter and shorter and shorter. A stage will come when the cervix is so short, there is no cervix palpable. It becomes a flat rim. So that is cervical effacement. The shortening of the cervix, because it is being taken up by the lower uterine segment, is called effacement. Okay, so that is cervical effacement. So you have both cervical effacement and dilatation. If these changes are there, it is true labor pain. Then the fourth thing is, these pains will not subside by giving any sedative. If it is a false pain, if there is a pain and then you give them a sedative, this pain will subside. Similarly, if you give an enema, if it's a false pain, it will subside. Whereas if they're true labor pains, true contractions of the uterus, nothing is going to stop it. You give them sedation, you give them an enema, nothing is going to stop it. It will continue. So the most important thing, as I told you, the first stage of labor is onset of true labor pains, which you have to identify by its progressive nature, associated cervical effacement and dilatation, inability to stop the contraction by either a sedative or an enema. That is true labor. Now, what are the other changes which take place in the first stage of labor? So, one was contraction, cervical effacement, and cervical dilatation, 3 stages. Now, one other thing is, you know that the cervix is a canal. It has an internal os, it has an external os. Now, between the two, you have a cervical canal, and it is filled with what is called cervical mucus, because the cervical mucus glands will be secreting mucus. Now, when the cervix dilates and opens up, what happens to this mucus plug? It can't stay there. So the cervix dilates and this mucus plug gets expelled. This mucus plug will be a little bit stained with blood because the cervix is dilating and the vessels, it's very vascular, So a little bit of bleeding from that can lead to a blood-stained mucoid discharge. This is what we call show. So there will be expulsion of show. If the patient complains that, madam, I'm having pain and there is some watery discharge, mucoid discharge, which is little blood stain, even without examining the patient, you know you are seeing the patient who is going into labor, because it will not be expelled unless the cervix opens up. So you have to correlate the clinical history from the and get an idea about the findings that you can anticipate. The first stage of labor involves contractions, cervical effacement, cervical dilatation, show. Now, once the cervix is fully dilated, what will happen to the membranes? The baby is surrounded by membranes, what are called chorion and amnion, and it is filled with amniotic fluid. So within the cavity, you have amniotic fluid and it is surrounded by chorion and amnion membranes, which are protected. Now, this membranes will no longer have a support, because till now the cervix was closed and the baby was inside and the membranes was covering it. Now, once the cervix opens up, the membranes will bulge and they form what are called a bag of membranes. They will bulge and form a bag of membranes, and a few more contractions. Increased pressure inside the uterus will lead to rupture of membranes. So there will be membranes will rupture and the amniotic fluid will come out. So that is the end of first stage of labor. So to repeat, first stage of labor, it takes about 10 to 12 hours in a primigravida. That means people who are pregnant for the first time. It will take about 10 to 12 hours because they're not used to it. It will take a long time. Whereas for a multigravida who has had a previous delivery, it takes much lesser time, like say 5 to 6 hours. Just like experience, when you have experience, you do things faster. Same thing. So a primary will take about 10 to 12 hours, whereas the multi will take much lesser time. So to repeat, first stage of labor, onset of true contractions, which are identified by progressive nature in duration, frequency, and intensity, not abolished by sedation or enema, and associated with cervical effacement and dilatation. Second, cervical effacement, which is shortening of the cervix because of its being taken up by the lower uterine segment. Third, cervical dilatation, that is opening of the cervix until it is fully dilated, which is 10 centimeters. Fourth, expulsion of show, that is the serum sanguineous mucoid discharge, which was present in the cervical canal, that gets expelled. Then fifth, formation of bag of membranes. And finally, rupture of membranes because of the increase in intrauterine pressure. So that is the end of first stage of labor. Now coming to this. So coming to the uterine action, the physiology of the first stage of labor. So coming to the physiology of the first stage of labor, the uterine action typically has a fundal dominance. Now, why does the baby get pushed down? Why can't the contraction occur in such a way that the baby gets pushed up towards the fundus? So that would lead to an ineffective uterine contraction. So the reason for such a coordinated action is there is what is called fundal dominance. Each uterine contraction will start at the fundus of the uterus near one of the cornua. Cornua are the corners of the uterus, and it spreads across downwards. So the intensity of the uterine contraction is strongest at the fundus and pushes the baby downwards. So the contraction lasts longest in the fundus, where it is most intense, but the peak is reached simultaneously over the whole of the uterus, and the contraction fades from all parts together. So what you have to know is it will start at the fundus at the cornal region. It is most intense there, and it pushes the baby downwards because the contractions start there and spread downwards to the rest of the uterus. Next slide, please. So that is a typical physiology of the fundus. Fundal dominance, what we call fundal dominance. One second, the slide is not moving. Yeah, just screen pieces. So when the labor begins, the retracted longitudinal fibers in the upper segment pull on the lower segment, causing it to stretch, and this is aided by the descending presenting part. So with each contraction, the baby moves further downwards and it reaches the lower part of the pelvis. Now, there is what is called a retraction ring. The ridge is formed between the upper and lower uterine segment, And this is called the lower uterine, the retraction ring, because the upper segment of the uterus has typically a different feature. That is, it causes contraction and retraction. Whereas the lower segment of the uterus has a principle of relaxation. It receives whatever comes into that. So this retraction ring is formed between the upper segment and the lower segment. Now coming to show, just before the beginning of the labor, a small amount of red tinged mucus may be passed, and this is the plug of cervical mucus mixed with blood. As I told you, that is what will happen. Now look at this dilatation. Dilatation of cervix is the process of enlargement of the uterine os from a tightly closed aperture to an opening which is large enough to permit the passage of the fetal head. So imagine the baby's head is almost 10 centimeters. If the baby's head has to come out, the cervix has to open up 10 centimeters. So it is measured in centimeters, and full dilatation is 10 centimeters. As you can see here, so it is here the cervix is closed. Okay, next it is just opening a bit, just a little bit opened here, maybe 2 centimeters. Here you can see it is opened further. Here says 5 centimeters, and here the whole of the cervix is open. That is, there is no more cervix left. You can't see any cervix left. The uterine wall is continuous with the vaginal wall. Nothing, no more cervix. So here the cervix was closed and it was protecting the baby. It started opening. It's just one finger, 5 centimeters, right? 10 centimeters. There is no cervix. The cervix has been taken up by the lower uterine segment. So this is the lower uterine segment, the part of the lower uterine segment. So here the baby is received. The rest of it is the upper uterine segment. Okay. So the cervical dilatation curve is divided into 2 phases. What is called a latent phase and active phase. So here the latent phase is the initial phase where duration is variable. It takes sometimes a long time. There is very little cervical dilatation, very slow. Here it is susceptible to sedation and anesthesia. So it might be altered by sedation and anesthesia. But once they go into the active phase, very, very fast the cervix will dilate. There is a phase of maximum slope. That means the activation occurs faster, and then there may be a deceleration, a slow phase. So there may be a rapid cervical dilatation, and then it will slowly decrease in its rate of dilatation. Okay, that would be, so that was just the features of the first stage of labor. Now coming to second stage. Once the cervix has reached full cervical dilatation, it will be onset of the second stage. Here, it will end with expulsion of the fetus. Now what has happened? The whole of the body of the uterus has become continuous with the vagina. There is nothing in between. The cervix was holding on, that cervix is open. The membranes which were covering the baby, that has ruptured. So all that has to do is the baby has to come out. So second stage involves delivery of the baby. So you can see the fetal uterus, and this is the head which is coming out. So here the nature of the uterine contractions becomes stronger, more severe, and there is what is called a bearing down effect. So the mother will also have voluntary contractions of the abdominal muscles, and the fetus is pushed down through the fully dilated cervical canal. And when the baby reaches the perineum, or the head reaches the perineum, and the perineum gets stretched, that point is called crowning. And finally, the head passes out of the outlet. So during the second stage, there are various steps. So there are about 7 to 8 cardinal movements like engagement, descent, flexion of the head, internal rotation, extension, restitution, and external rotation. These are some of the different stages through which the baby comes out. It's not as if the head has, once the cervix opens up, the whole of it will just open up and fall down. If that was the case, if the uterus was continuous with the vagina, we could make the patient stand up, and that itself would let the baby come out. But that doesn't happen for the simple reason that the pelvis is not a big canal. It's not one big cylinder that then you can make the mother stand up and the baby would just fall down. The pelvis is very small, narrow, covered with soft tissues, and the dimensions of the pelvis are different in different places. So at the inlet or the upper part of the pelvis, it is transversely oval. Inside the middle of the cavity, it is more or less a circle, and the outlet is anteroposteriorly oval. So if the head continues to come down in the same direction, it will get stuck. So it has to rotate along the direction of the pelvic cavity. So that is why these different movements that take place during the process are called the cardinal movements of labor. That is what happens in the second stage. So the head undergoes various movements and finally it comes out and the baby is born. So that is called mechanism of labor, which we'll have in a separate class. So for present, you can just remember that second stage of labor, normally which lasts about 1 to 2 hours, takes place and ends with the expulsion of the baby. So that's the end of second stage, and you have the starting of the third stage of labor. So what is third stage of labor? Now, once the baby has come out, what do? The umbilical cord is there connecting the placenta to the baby. So you will put 2 clamps on the umbilical cord, cut in between and separate the baby. And of course, you hand over the baby to the pediatrician to see how the baby is and then resuscitate if required. So now what is left inside the uterus? There is a placenta and there is a cord hanging over. And the end of the cord has been clamped. So now in the third stage of labor, once the delivery of the baby has occurred, it comes from the delivery of the child to the expulsion of the placenta. That is the third stage of labor. So here, if the placenta has to expel, what has to happen? It has to have 2 stages. That is separation of placenta. It is attached to the wall of the uterus. So first of all, it has to separate from the uterine wall. Then it has to get expelled outwards. So what will happen in this? In this, first of all, once the baby is expelled, the mother relaxes. That means there will be end of uterine contraction. However, once the uterus realizes that there is still something inside, that is the placenta, like a foreign body, it wants to expel that also. So what will it do? It will try to contract and push out the baby. So there will be uterine contractions. When the uterus contracts, the placenta which is attached to the uterine wall, the placenta cannot contract. It's not a muscular structure. So the uterine wall is contracting, but the placenta is not. So there will be a shearing force between the two. So each time the uterine wall contracts, there will be a shearing force between the placenta and the uterine wall, and a bit of it will separate. So slowly and slowly with each contraction, more and more of the placenta will separate, and there will be a bleeding because the vessels between the wall of the uterus and the placenta will open up. Initially, they will collect between the placenta and the uterine wall. So the height of the uterus will slightly increase, and there will be bleeding coming out of the uterus. Now, after more and more placenta separates, what will happen? A stage will come and the whole of the placenta has separated from the uterine wall. Then it can no longer stay there at the fundus of the uterus and the placenta will fall down. Where will it fall down? It will fall into the lower uterine segment. It will reach the lower uterine segment. So, there will be separation of placenta and it will fall in the lower uterine segment, which on the patient, it appears like a suprapubic bulge. If you see a patient, just above the pubic symphysis, it will be present at that area, so there will be a suprapubic bulge. And what will happen to the umbilical cord? Because the placenta has come down, the umbilical cord will come further down. And when you're seeing a patient from outside, you don't know what's happening inside. It looks as if the cord is lengthening, as if the cord is growing. So it is called apparent lengthening of the cord. Apparent lengthening of the cord. Okay. So in this stage, the placenta has got separated. It has come and fallen down into the lower uterine segment, and a few more contractions will cause expulsion of the placenta. So that it will be pushed out of the uterine cavity. Now, most often what we do is, it takes a lot of time for the placenta to get expelled. So we don't want to wait for the spontaneous contractions to expel the placenta. What we could do is, when we see that the placenta has come down, the cord is lengthening, that means it is in the lower segment, we apply traction on the cord. The obstetrician is there, will hold the cord and gently pull it. What will happen? The cord will pull the placenta out. Once the placenta is out, there's nothing inside the uterus will contract. Now, why we want to hasten this process is, until the uterus contracts, what will happen to the placental site? At the site of the placenta, there will be bleeding because the vessels were going from the uterine wall into the placenta. When the placenta separates, the vessels will be continuously bleeding, and that will cause loss of blood for the mother. So once you remove the placenta and the uterus contracts, those vessels will stop bleeding. That is why it's very important for the control of bleeding to hasten the process of placental separation and expulsion. Now, once the placenta has totally come out, the uterus will firmly contract and retract and maintain hemostasis. That's most important. Okay. So the things which occur in the third stage are separation of placenta, expulsion of placenta. Before separation, once we can just go back to that again. So how do you know that the placenta has separated totally? So you find that there's a fresh bout of bleeding. As I told you, that when the placenta separates from the uterine wall, there will be bleeding. The cord will lengthen. The fundus will elevate because there will be collection of blood between the uterine wall and the placenta. So the fundus will raise and it will appear slight increase in uterine height. And when the placenta falls into the suprapubic region, it will be a suprapubic bulge. Now, all these features will lead to what is called it will be indicators that the placenta has completely separated. Now, coming to the method of expulsion of the placenta. There are two methods of separation of the placenta. The placenta can separate from the edge. from one end of the placenta, or in the center. It can separate in the center of the placenta, so that when it comes out like an inverted umbrella. So in Duncan's method, the placenta will come from one end. The placenta will fold on itself so that the long axis of the placenta corresponds to the long axis of the uterus. So one end of the placenta will start separating, and that comes down. So when it comes out, you find the cotyledons will be seen. That is towards the maternal surface, and that will be very, very dirty. That's very simply, we remember dirty Duncans and shiny shoes. In the Schultz method, the placenta will separate in the center. When it separates at the center, it comes out as an inverted umbrella. So the retroplacental hematoma will form, which leads to more separation of placenta with each uterine contraction. So anyway, either method, however the placenta separates from the center or from the edge, the point is when the whole of it separates, it falls into the suprapubic region. Suprapubic bulge. So expulsion of placenta, it usually occurs within minutes after birth of the fetus. So maximum time that we allow for this third stage is 1 hour. And once the placenta has come out, the uterus becomes firm and hard and contract. So that is the end of the third stage. Third stage involves separation and expulsion of the placenta. Now coming to the fourth stage. What is the fourth stage of labor? What is left inside? The baby is out, the amniotic fluid is out, the membranes are out, the placenta, the cord, everything is out. Now what is left inside? So there is nothing to get expelled. But this is the stage of hemostasis, the most important stage. It usually is measured for 1 to 2 hours after delivery of the baby. Okay, so this is a stage of observation. Nothing is happening as such actively in relation to the baby. But most important thing is the mother is securing hemostasis, control of hemorrhage. Otherwise, what will happen? Every mother after delivery of the baby, if the placenta separates and that site where the placental vessels and the uterine vessels were in communication, if that continues to bleed, what will happen? Every mother would die after a delivery. So that vessels should get hemostasis. So how does it occur? Most importantly, when the uterus finds that there is nothing inside, it will undergo a strong contraction. And this is called living ligatures, because a strong contraction of the uterus. And you must remember that the muscular pattern of the uterine wall is crisscross. The myometrial fibers are arranged in a crisscross fashion. So when it contracts, the vessels which are passing through it will get constricted. And that is called living ligatures, because they are live ligatures that are constricting the wall of the vessels. Second, the vessels themselves will undergo what is called vasospasm, spontaneous vasospasm. You know, whenever there's injury anywhere, the vessels undergo spontaneous vasospasm. Third, there will be formation of blood clots. Any damage or trauma anywhere in the body will stimulate the coagulation pathway. And that coagulation pathway will cause stimulation of blood clots. Platelet plugs will form and they'll close the vessels. Most important, one other important thing is there will be, okay. So after that, there will be what is called opposition of the uterine walls. So the walls of the uterus will oppose each other. The anterior and posterior wall will be firmly adherent, so that there can be no space. There will be no space for collection of blood. So in the fourth stage of labor, there are actually 4 methods of hemostasis. I'm sorry for that slide. Actually, they've not added the fourth one. So first, most importantly, the uterus will contract, very strong contraction, which acts like living ligatures. The contraction of the muscle will cause compression of the vessels which are passing through the musculature. Secondly, there will be very good hemostasis because of the coagulation pathway. Anytime injury anywhere will cause formation of platelet plugs. So these will block the ends of the vessels. Then thirdly, you have spontaneous vasospasm. That is, the vessel itself will undergo vasospasm. And lastly, but not the least, you have uterine wall appositions. The walls of the uterus will oppose each other. And that will bring very close closure of. Now, the important reason why all this is we're talking about in the first stage of labor is, if any of these things don't happen, the patient will land up with profuse bleeding, what we call postpartum hemorrhage, and that's an obstetric emergency. Women can die because of postpartum hemorrhage. That means if the uterus does not contract, what we call atonic postpartum hemorrhage, or if there is trauma anywhere in the genital tract because of the process of delivery. That can lead to uncontrolled bleeding, what we call traumatic PPH. Third, if the coagulation system is at fault for some reason, if the coagulation system is not working, when it lead to DIC, what is called disseminated intravascular coagulation, DIC. That can cause a very dangerous situation, which can lead to uncontrolled hemorrhage and death. And then you can have retained bits of placenta. If the walls of the uterus do not close because of a small bit of placenta, then what will happen? It will not close and the blood will go on seeping there and collecting in the cavity. That is why during the third stage, when the placenta separates and the placenta comes out, it's very important that you put it in your hands and examine the placenta. Make sure the entire placenta has come out. If you find that there is some dip, there is some gap in the placenta, what does it mean? That bit of tissue is still inside the uterine cavity. And then what will happen if the bit is there? The uterine walls will not oppose each other. The uterus will not be able to contract, and that will lead to uncontrolled bleeding. So this stage is the most important stage. The first 1 or 2 hours after the delivery of the baby is your fourth stage of labor, when you will the uterus is securing hemostasis. So just to repeat, we have 4 stages of labor. So there are 4 stages of labor. The first stage of labor is involving onset of true labor pains to full cervical dilatation. That is the true labor pains, which are progressive in nature in terms of frequency, duration, and intensity. It is associated with cervical dilatation and effacement. Only if those changes are there, you call it true labor. And also, they do not subside with either sedation or an enema. Next, the next thing which occurs is after true labor pains, cervical effacement, that's shortening of the cervix because it is taken up by the lower uterine segment. Cervical dilatation, which is opening of the cervix, maximum up to 10 centimeters. Then expulsion of show. Show is nothing but the mucosanguineous discharge, which is present in the cervical canal. Expulsion of show indicates onset of labor pains. Fifthly, formation of a bag of membranes by the chorion and neo, and rupture of membranes. That is the end of first stage of labor, because of which the uterus becomes continuous with the vagina. There's no more cervix in between. So the passage is totally open for the baby to come out. That is a preparation for the baby to come out. So first stage of labor is a long process. It takes about 10 to 12 hours in a priming gravida. There are 2 phases, what is called the latent phase and then the active phase. In the latent phase, it is a slow initial part of the cervical dilatation where it can be influenced with sedation. If you give sedation, it might subside. But once it goes into the active phase, where the cervix is dilating in very fast, the acceleration phase, then of course there's a deceleration phase. In that part, no sedative can stop the cervical dilatation. Nothing can stop the progress of labor. Okay. So that is about first stage of labor. In the second stage of labor, the cervix is fully dilated, and the end stage is delivery of the baby. So the process of delivery of the baby occurs through a mechanism of labor where there are various steps. I'll tell that in the next class. So the baby engages into the pelvis. There is a deflection, descent, internal rotation, all that because they have to accommodate to the space which is available in the pelvis. The cervix, as I told you, the pelvis is not one big canal that the baby can just fall down. The baby has to negotiate through the curves in the pelvis and then come out. So that whole process or mechanism of labor takes place in the second stage and the baby comes out. Once the baby comes out, you clamp the cord in 2 places, cut in between and separate the baby. That is the end of second stage. That will mark the beginning of third stage wherein only the placenta is inside. The placenta will separate and expel. So the third stage of labor involves separation of placenta, expulsion of placenta. So the separation can occur from the edge of the placenta or from the center of the placenta. So if it is starting from the edge of the placenta, you call it the Duncan's method. And if it is starting from the center of the placenta and the whole of it comes out like an inverted umbrella, you call it the Schultz method. Either way, initially when the placenta is separating, there will be fresh bout of bleeding. The collection of blood between the placenta and the uterine wall causes a rise in fundal height. There will be then entire placenta when it separates, it will fall in the lower uterine segment. It appears as a suprapubic bulge, and there will be an apparent lengthening of the cord. Now, once you find all these features, you know placenta is fully separated. In active management of labor, you can actually pull the cord. What is called traction, counter traction. You apply traction on the cord and you put your hand on the uterus or abdomen so that you are holding the uterus steady. That is counter traction. Gently pull the cord and the placenta will come out. Now, why we do this is to hasten the or cut short the third stage of labor so that the bleeding from the placental site will stop. So that is the end of third stage where the placenta has come out. And it's your duty to always examine the placenta in your cupped hands and see if all the cotyledons are intact. If you feel that there's a gap there or one cotyledon is missing, it must be inside the uterus. It cannot stay anywhere else. And you cannot leave it. You can't say, okay, let us leave it in memory of this pregnancy. You can't do that because any bit of tissue which is left inside can lead to torrential postpartum hemorrhage. So then you will have to do a manual removal. You have to put your gloved hand inside and remove it, sometimes under ultrasound guidance. Anyway, that's a complication. So after the third stage of labor, when the placenta has come out, you will enter the fourth stage. Nothing is there inside, but in the fourth stage of labor, the mother is undergoing hemostasis, that is securing control over the hemorrhage. And how does it occur? 4 methods. One is strong uterine contraction. The uterine fibers are arranged in the crisscross pattern. So when they contract, all the vessels passing through it will get compressed and support living ligatures. Second, there will be vasospasm, spontaneous vasospasm. The vessels will go into spontaneous vasospasm. Third, there will be formation of platelet plugs. That is, the coagulation system will form platelet plugs. And fourthly, the walls of the uterus will oppose each other. The strong opposition of the uterine walls will prevent any seepage of blood because it will not allow any place for the blood to flow. So all these 4 things together will help in bringing about hemostasis and the end of labor. Now, after these 1 to 2 hours of observation, when you're sure there is no excessive bleeding, the vitals are stable, the patient's pulse and BP are normal, you can shift the patient to the general ward, wherever. So that until such time, because the first 1 or 2 hours are very crucial and they can go into uncontrolled hemorrhage when we call that postpartum hemorrhage. So that's a separate chapter, but you must be sure that all the bleeding has stopped. Okay. So I want all of you to read this chapter, make a very simple notes for yourself so that you know at least what are the events that occur in each stage of labor. That's very important. So, and you should be able to identify when a patient has really gone into labor. And once they go into labor, you should be able to continuously observe, monitor, and deliver the baby safely. So it's very important to identify which stage of the labor she is and assist accordingly. Okay. Right. So if you have any doubts on that, you can put it in the message box. Next class, I want all of you to come early so that we can start simultaneously. Don't keep joining, and I find some people are already leaving in between. So I think a lot of effort goes in for everybody, all the staff coming and preparing for you. Don't waste your time because these topics will not be repeated again and then you will lose track. Okay, so have a safe time. Be careful wherever you are. Make sure you are using these classes usefully.